Okay, so I'll be recording this session for educational purpose and then I'll be sharing it with you through my YouTube, a private YouTube channel. So today is the part two of the class that I already did. And if some of you were present in that class, they already know what we did, but I will quickly glance through that so that we can, have some nice transition instead of going abruptly into the next section. So, uh, the objective of today's class is that we will be, studying and discussing some more topic related to NAC. And today I will be talking a little bit about counseling, which is a very, very important component of NAC. In last class, I gave you guys an orientation about what NAC is, what does this exam looks like, what are the stations like, what is the time duration, time division, all those things. Any questions, if anyone has in this regard, you can ask me, stop me and ask me at this point. Otherwise, I will just keep on moving because we discussed it in the last class. I also discussed with you guys that what question stems would look like. It can be history physical, history counseling, history only, very rarely heard of examination, so don't bother yourself about that. So most of the cases would be history and physical and history and counseling. So usually, as I mentioned in my previous class as well, that most of the times what you are going to see is in the past few years, the pattern has been like this, that they are giving more cases of counseling. You will have one or two cases of physical exam, but counseling holds the major chunk of the exam. That is what my observation has been in the past few years. So we talked about time division in the last class. We talked about how to divide your time, what time you get outside the door. If anyone has any questions in that regard, you can stop me and ask me those questions. Otherwise, I'll just continue because we discussed it in the last class as well. Okay. All right. So sorry. So we also discussed about the this scenario of chest pain of a 40-year-old male who presents to you with chest pain and how to go ahead with that. We made some differential diagnosis in the last class. There was one volunteer who volunteered and she did a pretty good job with that. So we discussed the steps that what you have to do. You introduce yourself, you enter the room, and then we discussed how to make differential diagnosis. So the list of differential diagnosis should be a complete list so that you don't miss on anything. So usually we use this mnemonic split. I tell my students that they can use this mnemonic and try to have all sort of flavors in your differential diagnosis. You should have serious conditions, probable diagnosis, interesting diagnosis, something which is treatable, so that when in the exam you're dealing with all those diagnoses, you don't miss on to anything. We made this list of differential diagnoses and we discussed around these topics, very quickly, that what can look like a chest pain in the context of NAC OSCE. We discussed about basic history pattern, which I mentioned in the last class, that more or less your basic history pattern remains the same. There are some variations when it comes to pediatric groups or geriatrics or females in gynae ops, but usually the pattern stays the same. Then we discussed that how we narrow down our differential diagnosis. So you have a huge list of differential diagnoses and you have to narrow it down. So you will be asking some questions in history of presenting illness. Usually, what I tell my students is that you should be asking questions from the same system and at least two nearby systems. If you're not sure of your differential diagnosis, if you know the differential diagnosis, then you can ask specific symptoms of that disease. For example, a patient, young patient coming to you with chest pain, you're suspecting, pulmonary embolism or pneumothorax, the things that can show up in a younger age group rather than the older ones. So 40-year-old male smoker, a few things will come on the top of the list. So what questions to ask in that regard? If you are asking those questions, you will be asking about, leg swelling, recent long travel history, if you're thinking about pulmonary embolism and shortness of breath. So the examiner knows that you're thinking on those lines. Let's suppose you're not able to come up with any differential diagnosis, you are just lost and you don't know. Then at least try to ask questions from that particular system. For example, if it's a chest pain scenario, that means it is involving some your systems in the chest. So respiratory and cardiology will come on the top of the list. So you will be asking symptoms from the cardiac section and respiratory section. And what are those cluster of symptoms? I teach them in my course that every system has some cluster of symptoms and we need to ask them when you're taking the history. After that, you narrow down your diagnosis, and then you finally reach to the next part of your history taking. So when it comes to a chief complaint, as we discussed earlier as well, that we are sorry, we ask about onset, course, position, quality, radiation, severity, timing, impact, aggravating, relieving factors, and the risk factors that can be involved. So this much we discussed in the last class, and then we stopped at history of presenting illness. Now, taking you back to the scenario that we were having, we were discussing about a 40-year-old male who was presenting in the ER with chest pain. And during the discussion, we came to the conclusion that since he was having the chest pain since 6 months, but what recently changed that brought him to ER was that he was concerned that one of his friends had a heart attack and he might be having the same thing. So now your station changes from a station of chest pain, simple chest pain, which you are thinking of, to a counseling station, in which you have to address the issues that the patient has, and you have to counsel him about his disease and what steps to take forward. Now, in the previous scenario, the history pointed out towards GERD. So the patient had gastroesophageal reflux disease, and the only reason that he was here in the ER was because he was stressed. One of his friends was diagnosed with, a heart condition, a heart attack, and he thought that maybe he also has one. So now it changes the pace of your counseling. So this is the mnemonic that I follow for counseling, IBUX. So IBUX stands for number one, information sharing. Then you take a brief history. Then you ask the patient that what your understanding is. And after that, you ask the patient about their concerns. Then you explain the disease. How you explain the disease, you give them a brief explanation of the disease, the normal anatomy, physiology, causes, complications, what management is involved, and then you summarize it for them. This will help you wrap up your station in an organized way if you follow these steps. So when you know it's a counseling station, you have to start the counseling, then you have to share the information with the patient, and then you have to give the patient the all the options which are available, and then you have to set up a follow-up appointment with the patient. So you have to follow all these steps in order to make your counseling effective and score good marks. If you who would like to try counseling for GERD is more than welcome to volunteer. Yes, Dr. Akwagu, please correct me if I mispronounce your name.
Yeah,
Yes,
yeah,
go
I
ahead.
can volunteer.
Okay. Yeah, so I can give you like 3 minutes, and let's practice some counseling together, and let's see how it goes from there.
Okay.
You can take a minute if you want to write something or prepare your notes, or if you're ready, we can just go ahead.
Yeah, I can go ahead.
You're ready?
Yep.
Okay, let's start. So you have a 40-year-old male patient who presented in the ER. He had a history of smoking. We did this part in the last class, and you took the history and you found out that the patient actually had GERD from the sign symptoms, and he was having it for the past 6 months, and now he's here because he's concerned that he might be having a heart attack as his friend had one. So you have to counsel this patient now.
Okay, no history, just counseling, right?
Yes, we did the history section in the last class. This is the
Okay, I
part two
wasn't
of the
there.
class. Yeah. Oh,
I
you were
wasn't
not
there
here.
for
I'm
the
so sorry.
history. Yeah.
Yeah, so there was a volunteer and we did history of presenting illness and in the last class. So today is the counseling.
Oh, okay.
Yes, go ahead.
So, okay. Yeah, I want to ask you, do you know what might be wrong with you?
Yes, doctor. It's just that, I get this metallic taste in my mouth and it has been going on for a while. And, this chest pain with this, it's really bothering me. So I was just concerned that, maybe it's a heart attack because one of my friends, he recently had one. So I got a bit worried that, I'm just putting this chest pain, and I'm not taking it seriously. I'm putting it away all the time. So I just wanted to make sure that everything is fine. That's why I'm
Yeah.
here.
Yeah, I know you have the right to be worried, but I'll assure you that from the history you've given me so far, and I think what you might be having is what we call GERD. I don't know if you've heard anything about that. Have you heard about that before?
No, doctor, can you explain more about it, please?
Oh, yeah, I will do just that. So GERD is gastroesophageal reflux disease. So it has to do with it's a medical term that is used to describe when the stomach, because when we eat, the stomach has something we call sphincter, and the sphincter is what closes up the stomach to retain the food in it. Okay, so when the sphincter is weak and the food we eat or the acidic content of the stomach, because the stomach contains acid, so the acid kind of flow out of the stomach into the esophagus. I don't know if I'm making sense.
Mm-hmm.
Am I making
Doctor?
sense? Yeah. So,
Yeah.
okay. So, in case you have any questions you want to ask me in between, you can stop me at any time and ask me. Okay. So, the content of the stomach kind of outflow through the sphincter and it goes to the esophagus, giving you that sensation of a burning pain that you experience. Okay. So, but
Mm-hmm.
I want to tell you that there are so many things we can do to help you so that you don't experience those symptoms again. Okay,
Mm-hmm.
can
Mm-hmm.
I go ahead?
Yes, doctor, please go ahead.
Okay, so there are certain things because if it's not taken care of, it can lead to some complications. Okay, so now
Mm-hmm.
you're already having those burning sensation in your chest, which is making you very uncomfortable. But there are certain things you should do to avoid, having those symptoms, such as maybe not eating so late at night, or let me say, eating 2 hours before sleeping. Okay.
Mm-hmm.
And again, avoiding some spicy food. Avoiding some
Mm-hmm.
spicy food can help you very well. And not lying down immediately after eating. Okay. Am I
Mm-hmm.
making sense?
Yes, doctor.
Okay. Yeah. So these are the things you can do to avoid it. But there are also some medications that can be given to you to stop you from experiencing these symptoms. Okay.
Mm-hmm.
Okay. Do you have any
Okay.
question at this moment for me?
No, doctor, please go ahead.
Okay, so there are some medications that would have to give to you to take to help relieve those symptoms. Okay, so which are available for us to give you. So, but then again, you have to watch what, as I said, watch what you eat. Um, Try not to sleep immediately after eating. And there are some materials. There's actually some materials available for you, and there are some websites which I can provide for you to make inquiries and read more about this to be able to understand it better. Okay. So
Mm-hmm.
you can read that, and there we can even book an appointment maybe in the next 1 week if that's okay by you, so that you can come back when we must have given you those medications to see how you're going. Is that okay?
Yes, doctor, I would like to have the medications. I think they will help me to get rid of this. And I'm really worried about it because I really don't want to have a heart attack like my friend.
Yeah, okay. So I know you're worried, but this is not the same thing as heart attack. The pain are different. Heart attack has to do with the heart, but this has to do with your GIT. That is your gastroesophageal, where you eat food and it gets to your stomach. They don't have the
Mhm.
same connection. They are not connected at all. So it's a different pathway. So it has nothing to do with heart attack. So you're not going to have heart attack. Okay.
Okay.
Okay. Do you understand what I'm saying?
Yes, doctor. Yeah.
Okay. So can you in your own little way kind of explain to me what I have said so far, if in your own understanding, can you?
Yeah, so you explained to me that this is related to my stomach. The pain is related to my stomach, and I need to eat a bit earlier, and don't eat late at night. And you are giving me some medication that I can use, and if I don't get better, then you will do some more tests.
Yes, exactly. That's what I said. So and I said I will give you some medication to help you with the symptoms before you go. Okay?
Okay, okay,
Yeah.
okay, okay. Thank you very much. So,
Yeah.
doctor, when should I come back if my symptoms don't get better?
Yeah, when your symptom gets worse, you just have to come back. Maybe if it becomes so severe, you have like excruciating chest pain. If you're having upper, like your abdomen, the upper part becomes severely painful, you can come back. Okay. If the metallic taste become worse, if you have difficulty with swallowing, if you have developed fever, yeah, if you
Mhm.
poo and the poo has color, either red or if it's very dark, you should please either you come back to the clinic or you call 911. Okay.
Okay, doctor.
Yeah,
Yeah.
that's it.
Okay, thank you.
You're welcome.
So, Dr. Ekwagu, you did a very good job. When it comes to counseling, a few things here and there that I will just like to add. And the reason is that I know, like, all of you are in the initial phase of your preparation. But the sooner you start organizing your counseling, the better you will be by the end of, your preparation time. So near the exam, whatever topic comes, you will know how to deal with it. Now,
Yeah.
first of all, there are certain topics like GERD or MI counseling or counseling about preeclampsia. These are some of the topics which are very, very common topics. Every day we see them in family practice, family medicine practice. So
Mm,
when these topics come, they actually need a lot of attention, and a lot of what I would say that the way you will interact with the patient, you will be highly tested on that. The reason is because the entire Canada will be scoring a lot of marks on these topics, because it's an easy topic, it's not a difficult one. So if your counseling is a little bit, more like there are various types of counseling. One counseling is that you give everything in like a one long lecture or speech, and the other way is a conversational counseling. Uh, Personally, I feel that conversational counseling is more effective to the examiners because they give you more marks. And what is that counseling in which you make the patient speak more? Now, the same information that you are giving, let the patient talk to you rather than you giving that information. Now, how are you going to do that? So, for example, first of all, let's start with the first thing. When you did the explanation of the condition that it is called GERD, and have you ever heard about it? So that was a very good thing. You have to check back with the patient that have you ever heard about it? Do you know about it? So that is called checking back. The next thing is that in counseling, you cannot use jargons. What are jargons? The medical terminologies. So instead of using esophagus, you can use food pipe. Okay, you can tell the patient that we have a food pipe, and because if you use jargons, you will not just lose marks, but overall the impression would be, or the patient might say, "Oh, what is that?" I don't know. So medical terminologies are a no. The other thing is instead of saying sphincter, you can say a valve
yeah.
or a gateway. Yeah, that would be an easier term for them to understand. So when you're explaining, you explained the pathophysiology very nicely that there's a food pipe and sometimes it get loose or it doesn't close properly and the acid comes back into the food pipe, and that's why you are having this chest pain. Now, after that, when you come to the management part, so first of all, you'll tell the patient when you start your counseling that, okay, whatever the name of the patient, let's suppose it's James. So, James, thank you for sharing all the information with me. So, from whatever we have discussed so far, I feel that the pain that you're having right now is related more to your stomach rather than to your heart. But just to put you on ease, because you are smoking, you're 40 years old and you have been smoking for a long time, the risk factor is there. I will be doing an ECG for you today just to put you at ease and make sure that everything is fine. But regardless of the fact, I feel that, this is more related to your stomach. And then you explain the pathophysiology. And then the next part, you will come to the management. So you tell him that, okay, James, the condition that you are having right now, we have the good part is that it is very much a manageable and treatable condition. There are two ways of managing it. One is the lifestyle modification, and the other is the medical treatment that we have on board. Lifestyle treatment will help you for with the initial settlement of this problem. So, can you walk me through a day in your life and tell me how does that day looks like? Okay, so then let James talk. Let him tell you that, okay, doctor, I wake up in the morning, I take a cup of coffee, maybe I eat late at night, I eat spicy food. So when he's talking to you, then talk to him. So James, as you mentioned that, taking this cup of coffee is triggering your factors. So there are other reasons as well that can cause this GERD, trigger this disease. They are like, weight gain. So have you recently gained any weight? So let him, ask him. So if he tells you this, oh yes, doctor, maybe I gained, 10 pounds in the past 5 to 6 months. So James, whenever you're ready, we can set up an appointment in the next session, and I can refer you to a nutritionist who can tailor a plan according to your needs. Ask about the coffee intake, tell him to set up an appointment for the smoking cessation, that you are a smoker, you have been smoking, so whenever you feel like quitting, we are here to help you, and the smoking can also trigger it. So take one by one. Why are you asking all these risk factors and addressing them, or letting James answer you all these things? Because you are going to tailor your management for this patient according to that. So for this patient, you will be giving him lifestyle modifications. You will be giving him PPIs. You will be telling him about referrals. It's very important, where to refer the patient. So you will tell him that, I will be sending you to a nutritionist. I will be setting another appointment. Then follow-ups, that when the patient should come back to you. So I'll give you these medications. You have to take them 30 minutes before your meals. And after that, I'll see you in 1 month. 1 month, 2 months, 3 months, whatever the scenario is, the timeline according to that. Then, in the end, you will be discussing red flags and safety netting. Very, very important. So, you did discuss about the red flags that, James, if this pain gets worse, you talked about all those things that come to the ER. So, that is very important. And safety netting as well. That if you ever feel that the nature of pain has changed, it does not look like the pain, the way it is right now, the nature changes, you start getting any sweaty hands, you get nausea, vomiting, please come back to the ER. Okay, so this is how you are going to, and then you tell him that, okay, I'll see you in a month or in 10 days or whatever timeline you have chosen. If they ask you further that what are the complications, then you can talk about complications of PPIs, that right now for a month it is fine. But if your symptoms don't get better, then we have other tests on board, like, putting a camera down your throat, just to see that what's going on there. So you talk about H. pylori later on. In the history, you can ask those questions. So this is how you are going to give the same information, but in slightly different way, so that it is more effective. The patient is talking more to you. The patient is telling, "Oh, doctor, I wake up at this time. I drink my coffee. I go to work. I do this, this, this. Are there any stressors in your life?" Because all the risk factors that are there, you will bring them into counseling. Okay. Any questions that you have?
Yeah, so like those risk factors, is it possible to get them during the brief history taken, like his diet, his small other stuff? So like we'll get the information more during brief history so that we can use it to counsel the patient during counseling.
Yes, yes, it's up to you. Wherever you feel comfortable, like everybody has their own style. So I always tell my students that have your own unique style. So
Mhm.
if your style is that you're more comfortable in taking the history first and then addressing them later, even that is fine. If you're more comfortable in bringing it in the counseling, even that is fine. The only thing is that you have to bring it in at
Mm,
any point. So as a physician, whatever your natural style is, stay
mm.
with that and ask the questions according to that.
Okay, okay. Thank you.
Yeah, you did a very good job, and thank you for volunteering.
Yeah.
Okay. Any other questions? Okay. So no more questions. All right. So this is how basically you have to address counseling stations. Most of them, the normal counseling stations, they will be like this. You can have different sort of counseling scenarios, which can be ethical scenarios, they can be grief related scenarios in the exam. Um, so it all depends what you get. But for simple disease and its counseling, if you follow this structure, you will not be missing on to anything. So no questions so far? Okay, so I'll just move forward. All right. So this is how we, counseled a patient of GERD. You explained what the disease was. You emphasized upon lifestyle changes, medications which are available, when to seek help. Then after that, wrap up, summarize the plan, lifestyle changes, address any concerns that patient have, any problems that the patient have for adherence to the regime, especially in elderly patients. You can have patients who will be having some trouble with their adherence to the regime, and then you tell them when to come back, when to reassess, when to get worried, and the safety netting. So this is a brief example of counseling. Any questions that anyone has so far? So I'll be moving forward if you don't have any questions. Okay. So this is the detail of the boot camp that I'm offering. I already posted one schedule on my Telegram channel, but a lot of students mentioned that they are busy with some QE1 exams or preparations, and they would like to start a bit later. So I have moved the date a little bit forward, and I'm starting from the 15th of December, the weekday batch. So I'll be running two batches, one on the weekend and one on the weekdays. For the weekend, it would be Saturday and Sunday morning, and timings would be 7 to 11 Mountain Standard Time in the morning. And for the weekdays, it will be usually Monday and Thursdays, and a few more days in the month of December because of the New Year and Christmas, holidays. I have added some more days in the week, but usually it's 2 day. It will be 2 days, and the fee for the entire course is 800, and usually, my plan is to cover 140 to 160 high yield cases. A number of students in each batch, I don't take more than 12 to 14 students because I want each and every one of my students to perform in the class. If the batch is smaller, it gives more practice to the students, and which is the whole requirement of NAC OSCE. So usually I try that everyone gets one case to present in each class. If not, then at least if somebody is absent or the batch is smaller, then they even get two cases to present. These will be the units that we'll be covering, total 16 classes, and we will be covering it in almost 1.5 to 2 months. These are This is the detailed schedule. I'll be posting it on Telegram channel as well after the class. So I plan to start from 13th, which would be next week, not this week, because some of the students wanted to start later as well. I, in fact, wanted to start the session in January, but I got some requests that students wanted to start in December. So that's why I was doing it a bit early. But if I get more students who want to start in January, then we can all together we can start it in January. This is the plan for the weekdays. So Monday, Thursdays mostly, a few Tuesdays here and there are there, which are there in the schedule. These are the topics that we will be covering. So in cardiology, you can see we have almost 15 topics. We will be, talking about these topics and the scenarios around them. In respiratory, we have almost seven high yield topics. I even give X-rays, high yield X-rays and ECGs with cardio and respiratory units. Other than that, in GIT, we have almost 17 topics. Then nephro-euro, you can see almost 7 topics, which are high yield, important, cover all aspects. Then some MSK topics. Neurology, we have almost 14 topics that we cover. In endohematology, almost 7. Then we have some miscellaneous topics from here and there, which are like electrolyte disturbances and vitamin deficiencies, all those things. Then OBS Gynae, almost 12 important topics related to counseling and related to um, the gynae obs. Then in pediatrics, we have almost 16 topics. Pediatrics is high yield. You always get one station of pediatrics in your exam. In psychiatry, we have all these topics, and we have scenarios that talk about all these things. Any questions or confusions? that you might have. So no questions. So this is my email address, medicinebyheart@gmail.com, and this is the link to the Telegram channel. If you have any questions, anything that is confusing or you need guidance about, feel free to drop me a message, and I'll be more than happy to help you. So thank you everyone who was able to join the session today, and I wish you all the best for your exams and for all the other milestones that you have. So thank you very much for joining the today's session.
Thank you so much. Thank you.
You're welcome.